Well, we want to welcome everyone today to this Facts, Faith, and Friday. As you know, that this is one of my favorite times of joining with you all in the context of giving our information that we think is not only valuable, not only interesting, but also useful. This is another Facts, Faith Friday where I think we're going to have an amazing lineup today. As you know, we've had Dr. Brown, but we also have a special guest with us, someone that I am just I not only respect, but I like a lot. And when they say the apple doesn't fall far from the tree, or the proof is in the pudding, she has, as the first cancer center director for the NCI, woman cancer center director. But beyond that, she's just fantastic. But you'll hear more about that later. I did want to give you some good news. Sometimes when I'm on these things, I have been credited with only giving bad news. Well, I'm going to share some good news with you today that I think will continue to hopefully progress, that the science is actually working and that the science is being brought to the community. I'll give you one quick factoid. You know that I am very interested in lung cancer. And for a very long time, we know that African Americans, that lung cancer is still one of the leading causes of cancer death in the United States. And we know that African American men in particular, and the African American community has actually had a preponderance of poor outcomes. If you look at the new AACR report that we were a part of here at VCU, what you'll recognize is that for one of the first times, we've actually closed the gap between Black and whites in the context of overall cancer death, but also in lung cancer. So the question becomes what all the research does. Well, the research actually does do good in the context of when we can bring it to the community, it does have impact. You'll hear that as a recurring theme. I'm going to just welcome you all. I know we have a packed day. I'm just going to say that, so for those who have been keeping count, I do give good news. I gave some good news on COVID too at once in a while. But we actually do have some good news to talk about with cancer. I was going to turn this over to Rudene, Sister Rudene, and then we'll just get things kick-started.
Thank you, Dr. Winn. For those of you who don't know me, I'm Rudene Mercer Haynes. I'm happy to be with you this beautiful Friday. We have got lots of great news. We have with us Dr. Monica Bertagnolli, who is a trailblazer in many respects. I will introduce her shortly, but as is our normal custom, we start this conversation with prayer. And I'd like to turn it over to Reverend Tyrone Nelson to lead us in prayer.
Join me for a word of prayer. Dear God, thank you for these moments that we have to focus on things that are so very important to us. We ask that you bless those who are presenting, those who are sharing, informing us, seeking to empower us or challenge us. God, we pray for the 150 plus people who are on this call trying to receive information. God, our prayers for our community here in the Commonwealth of Virginia, in the Richmond region, Tidewater, and beyond. Bless us so that we can be a blessing to others. This is our prayer in your name. Amen.
Thank you, sir, and thank you for being a blessing in the community. Now we're going to turn it over to someone who really doesn't need any introduction. We've been very blessed to have a resident therapist for the Facts and Faith Friday crew. I am talking about Dr. Jessica Young Brown. I am going to be a little formal here and actually give you some of her bio, but most of the regulars for Facts and Faith Fridays know exactly who Dr. Brown is. She's a licensed clinical psychologist who works as a clinician, educator, consultant, and speaker. She's an assistant professor of psychology at Virginia Commonwealth University. There, she teaches in the area of applied psychology and coordinates undergraduate internship experiences. Her research and clinical work focus on making mental health accessible and equitable for people in marginalized communities and equipping mental health professionals to better serve these communities. Dr. Brown's areas of consultation include the impact of racism and race-related stress on mental health, generational and cultural trauma, and the intersection of faith and mental health. And again, Dr. Brown has been an invaluable resource for our pastors and lay leaders in the Facts and Faith community, always prioritizing taking care of our mental health so we can take care of the health of our parishioners. Again, Dr. Brown, I know you're going to tell me why did I have to read all that, but I wanted people to know that we're dealing with someone who's amazing in your area of expertise. So, Dr. Brown, I'm going to be quiet and turn it over to you.
Well, thank you, Rudene. I'll allow it. That's your one time for the calendar year of reading my bio. So hopefully we're done with that. Welcome, everybody. I wanted to just give a highlight of an experience that we told you all about several months ago. If you're one of the regulars on our call, we recently wrapped up the first part of a collaboration with Virginia Union University, the School of Theology there. And so I wanted to just share some highlights from that experience to tell you a little bit about the breadth of the things that we do as a part of this program. So we partnered with the School of Theology at Virginia Union to apply for a grant from the Wabash Center to do what we called a trauma-informed congregations symposium. A part of what we recognize is that you all as faith leaders are managing your own mental health experiences, simultaneously trying to help your faith communities navigate those experiences. So we teamed up to try to educate particularly seminarians and seminary faculty, but also the larger community around what trauma-informed care in congregations looks like. So I wanted to just share a little bit of what we did that weekend. So the first piece is that we collaborated with Virginia Union to essentially sponsor their community formation event, which is the signature event that starts the academic year. So it's a call to everybody in the Virginia Union and community to come together. And we focused the whole weekend on trauma-informed care. So we had a Friday night worship experience, and the guest preacher for that experience was Dr. Tama Bryant. Many of you might be familiar with her name. She's the 2023 president of the American Psychological Association. She's a psychologist. She's also an ordained minister. And her work really centers around holistic trauma care. So she preached on Friday night to really set the spiritual foundation for what it looks like for churches to attend to trauma in the context of our faith and spiritual lives. And then on Saturday, we held a symposium on trauma-informed care. This is our Facts and Faith Fridays team with Dr. Bryant. And so you might see some familiar faces in this picture because one of our intentions was this recognition that some of our Facts and Faith Fridays clergy are doing excellent, embodied, engaged, theologically responsible work in their congregations and in the community. And so we wanted to highlight that. So the first piece we did on Saturday was a panel really around trauma-informed care and practice. So you can see we brought out some of the big dogs here in our community for this panel to really talk about their experiences. 3 of these folks are actually on the call this afternoon to talk about how they manage, explain, talk about, live out trauma-informed care in their ministry work and community lives. And I have to tell you, a month later, people are still talking about how impactful this panel was. People are still talking about how much it changed the way they understand trauma-informed care and even understand their own experience. Then we had workshops on 4 topics that people could go to. These are the topics that we covered. We brought in experts from the community to get people exposed to some of the common topics that we often see in churches and tie those issues to basic trauma-informed care practices. And then we ended the day with what we called listening circles. Our goal was to have people get knowledge over the course of the day, but to also end the day figuring out, what can I do with this, right? What are the nuggets that I can take home and actually apply and practice, whether it's in my personal life, in my community work, or in my ministry work? And so we had folks who are community leaders to also convene those conversations and have people reflect on the experiences. So in addition to this, I've also been working with the faculty at the School of Theology to do some training around trauma-informed education. And I'll just let our Facts and Faith Fridays team know, people are waiting for part 2, right? So this is the beginning of an experience that was really impactful for all of us who attended. And we're really just getting the ball rolling. So we hope as we continue this kind of programming, you all will be able to join us and partner. Thank you. That's all I got.
You know I'm going to ask you a question.
I know you are, Rudene. I'm ready.
So, in faith-based communities and settings, people don't want to talk about trauma that happens in the household because what happens in people's household, people like to keep it there, right? So,
Yeah.
Can you tell me a little bit about how folks sort of navigate these sort of sensitive conversations?
Yeah. So part of how we wanted to kind of level set the conversation was just to think about all of the different ways trauma can show up for us, right? Trauma isn't just a car accident or a natural disaster. We talk about health diagnoses, right? It could be a cancer diagnosis. It could be dealing with a chronic illness. And a part of what we wanted to help people to do is to understand what are some of the common reactions we have to those really life-changing, safety-shaking experiences, and to normalize that it's scary and we can take action while we're scared when we have appropriate support and we're able to care for ourselves. One of the things that came up in the panel was people talking about how issues around their health actually impacted the way they showed up in other areas of their lives, right? So if I'm dealing with this health diagnosis and my doctor's telling me I've got to change my whole life, but I'm still expected to show up at work and pretend everything is normal when it's not, right? How does that impact the health decisions that I make? How does that impact the way I work with my healthcare providers? How does that impact the way I understand my own treatment, right? And the medical doctors on the call will tell you that when folks are able to care for their psychological health, when they're able to have social support, when they're able to have a positive outlook, that has a positive impact on their medical treatment, right? And so we want people to be able to understand themselves as whole, integrated human beings, and for the church to be a place where people can bring all of themselves and feel like there's space for us to hold that. That's really what trauma-informed care is all about.
Well, Dr. Brown, I've told you this countless times. Whenever I'm in your presence, whether it's virtual or physical, I feel calmer. I feel more at peace. I feel more all the things. So thank you for what you're doing in the community. Dr. Winn, did you have a question for?
Yeah, I was just going to say either for Reverend Rachel or Dr. Sutton or Dr. Brown, in the context of understanding that, that the Facts, Faith, and Friday is really a combination of a community and the cancer center. As you're thinking about trauma-informed care and those types of deals that are going, did you guys discuss at all any of the things that the trauma that centers around actually being a cancer patient, not to mention diabetes and all these other things, but just being a cancer patient? And did that come up in your discussions, and how have you dealt with that, or how are you addressing those issues?
Sure. It's interesting. It came up on the panel, but it also came up in the listening circles at the end of the day when people were trying to metabolize the information that we talked about. A part of the realization for people was, maybe I haven't named this yet, but as we described what trauma is and how it impacts us, they realized, oh, this is what was happening for me when I was going through treatment, right? And so then our work is helping people to identify that and think about, what is a healthy path for me as I navigate this space, right? Cancer treatment, we know, is inherently disorienting, right? It changes your life in all of these different ways. And our work is to help people to figure out what health looks like while we're going through treatment, right? I don't have to only be healthy when my doctor says I'm in remission and I have a clean bill of health, but there's actually a way I can envision health for myself while I'm navigating this process. And a part of what we believe, right, is that the church can be a vital part of that process for people when we're able to really understand and attend to the disorientation that people have as a part of that process.
Have I told you recently how much you rock? Have I said that?
Look,
So you put people at peace and you're a rock star. You're both of those things, Dr. Brown.
Listen, I don't know if I've ever shared this with you. My father went through cancer treatment, right? So I know what it's like to be in a family that is shaped by the experience of treatment. And he was a pastor. So I know what it's like to be in a church that is shaped by the experience of treatment, right? This isn't unfamiliar to us, but we can always bring more tools to the process so we can move through it in a healthier way.
Awesome. Thank you so much.
That's awesome, Dr. Brown. And you almost brought me to tears, so I got to keep moving. Again, thank you for being here, Dr. Brown. But we're really excited to also have with us another rock star, trailblazer in all fields, the director of the National Institutes of Health, Dr. Monica Bertagnolli. And I know you told Dr. Winn that he could call you Monica. I'm not going to do that. I'm going to call you Dr. Bertagnolli. But I'm going to read your bio because it's incredible in every way, and hopefully I'll do it justice. But you're the 17th director of the National Institutes of Health. You were nominated by President Joe Biden on May 15th, 2023. You were confirmed, hallelujah, by the U.S. Senate on November 7th, 2023, and you took office on November 9th, 2023, all very important dates. But what makes Dr. Bertagnolli so special, she is the first surgeon and the second woman to hold this position. As the NIH director, Dr. yes, celebration. That's amazing. Dr. Bertagnolli oversees the work of the largest funder of biomedical and behavioral research in the world. She previously served as the 16th director of the National Cancer Institute, again, rock star, the Richard E. Wilson Professor of Surgery and Surgical Oncology at Harvard Medical School, a surgeon at Brigham and Women's Hospital, and a member of the Gastrointestinal Cancer Treatment and Sarcoma Centers at Dana-Farber Cancer Institute. Throughout her career, Dr. Bertagnolli has been at the forefront of the field of clinical oncology. Her laboratory focused on advancing our understanding of the genetic drivers of gastrointestinal cancer development and the role of inflammation as a promoter of cancer growth. As a physician scientist, she led translational science initiatives from 1994 to 2011 within the NCI-funded Cooperative Groups Program, now known as NCI's National Clinical Trials Network. And from 2011 to 2022, she served as group chair of the Alliance for Clinical Trials in Oncology, a National Clinical Trials Network member organization. In addition, when do you sleep? In addition, from 2007 to 2018, she served as the chief of the Division of Surgical Oncology for the Dana-Farber Brigham Cancer Center. Dr. Bertagnolli has championed collaborative initiatives to transform the data infrastructure for clinical research and is the founding chair of the Minimal Common Oncology Data Elements, MCODE, Executive Committee. She also is a past president and chair of the board of directors of the American Society of Clinical Oncology and has served on the board of directors of the American Cancer Society and the Prevent Cancer Foundation. In 2021, again, you have many accolades, but this is pretty impressive. She was elected to the National Academy of Medicine, having previously served on the National Academy's National Cancer Policy Forum. The daughter of first-generation Italian and French Basque immigrants, Dr. Bertagnolli grew up on a ranch in southwestern Wyoming. I have so many questions, but I'll reserve those for later. Amazing. She graduated from Princeton University with a Bachelor of Science in Engineering degree and attended medical school at the University of Utah. She trained in surgery at Brigham and Women's Hospital and was a research fellow in tumor immunology at the Dana-Farber Cancer Institute. I am a lawyer by training, but sometimes all these medical words get me kind of, little discombobulated. But anyway, Dr. Bertagnolli, again, it's a real blessing for us to be able to sort of share the same space with you today. I have admired you from afar, and I appreciate your journey. But with that, I'm going to be quiet and I'm going to turn my camera off and I'm going to yield the floor to you.
Well, thank you so much for that just so gracious and generous introduction, and all of you for allowing me to be here with you today. As I was telling Dr. Winn, I've been looking forward to this for a long time, and I'm just so glad it finally became possible where we got to spend some time together today. maybe we can put up the slides. Start with those. So I was going to introduce myself, but there's been such a thorough job done. I'm going to skim through those really quickly and just tell you a few things I think that kind of do define how I feel about my profession and my life, and then talk a little bit about my vision for NIH, and then a specific update on what's going on with what NIH is trying to do to conquer long COVID. Next slide. So I am a surgeon. First time I walked into an operating room, by the way, I wanted to be an immunologist. I wanted to be, a medical doctor, take care of patients in the clinic, do immunology. And then I walked into an operating room and, oh my goodness, that's where I belonged. I felt that way. So I was so privileged to be able to pursue a career in surgery. This is me, just this year. No longer the big surgeon in charge, but this lovely woman right beside me there. I'm on the right, far right. The woman right next to me there is Dr. Stephanie Goff, who was one of my fellows in the research laboratory and a trainee in surgical oncology, and is now one of the senior surgeons at the NIH Clinical Center. And it's a beautiful thing because I get to be her first assistant, and that is an amazing honor. And I'm not going to go through all of this stuff, but what I am going to say is you see down there on the left, that beautiful mountain back there, those beautiful animals, that country. And I was so fortunate. I got to grow up in the West in this beautiful land, with wonderful family, wonderful community. But something very important about it, it's 100 miles to the doctor's office. It's 100 miles to a hospital. And so I grew up in an environment like that. My inspiration to be a doctor came from my uncle, who was a primary care doctor who took care of the veterans in Wyoming, all of the veterans in Wyoming. And Wyoming is a big place. He would travel across the entire state and take care of the vets. They were his responsibility. And I just adored him as my uncle and inspiration. And he taught me so much about what it is to care for people everywhere. Eventually, I had wonderful colleagues in the academic world, got to meet so many people through the work that I did, and eventually came to NCI as the director. And it was pretty soon, another thing I love to share with you, pretty soon, 6 weeks after I became NCI director, I got my own cancer diagnosis. I went in for a screening mammography, and there it was. Had a biopsy immediately, and I was on somebody with cancer's journey. So those of you out there who've had this disease, I feel solidarity with you. And I will tell you, I am so grateful. I'm fine. Gone through my chemotherapy, surgery, and radiation, all three, and I'm incredibly well and feel well, and my prognosis is wonderful. But let me tell you, why am I doing so well? It's because of the work that was done by the National Cancer Institute over many, many decades. And even more important than that, it's because I added them up. It's because of more than 140,000 women who agreed to be in cancer clinical trials for breast cancer, for the kind of breast cancer I had. And everyone asked me, well, what's the thing that's really been different about a surgeon and a cancer specialist having cancer? What's the thing that you didn't expect? I just can't tell you how actually living this myself has made me so profoundly grateful to those women who had the courage and generosity to deliver for me the treatments that have been so successful. So incredibly grateful. Okay, now let's shift to my new job. I am very worried that the health of the US population isn't getting better. It's actually declining. And I'm sure you all know this because you're living it along with me. The decline is steepest among people who are underserved and underrepresented. Well, that makes sense. We do have a lot of miracle things that are happening in medicine, but they don't get to everybody. And that is a terrible tragedy and something we absolutely have to counteract as soon as we possibly can. This is just the facts, looking at one crude way of showing that we're not doing so well. Our life expectancy was going up all the time, and now for a while it's been declining, and it really took a hit with COVID. I guess that's expected. Terrible, terrible disease. But we haven't come back to where we should be. And we spend more in America on healthcare than any other nation in the world. But you can see here, our life expectancy compared to other nations is far lower. Look who's high on this list: Japan, Switzerland, Korea, Australia, Spain, France, Canada, China are all ahead of us. And in fact, our life expectancy is equal to the nation of Vietnam, which hasn't had the biomedical innovation that the US has. So there's something very wrong here that we need to pay attention to. Next slide. And of course, we pay so much more for our healthcare. So we're not getting a good return on our investment here. You can see here that it's not even close comparison of how much everything is paid out. If you averaged it out per capita on the US population compared to our other nations that are doing so much better in safeguarding the health of their people. Next slide. So what are we going to do about this? What can a research institution do about this? Next slide. Well, here's first and foremost on the list. If you look at a map of our nation and you look at healthy life outcomes, economic advantage, if you look at all the favorable factors, and then you look at where the favorable social determinants of health, and you look at where we have poor health and their inverse maps, right? It's crystal clear that our map shows us where people are being left out. People are having inferior health. But the same thing with that map is it's also the same people that we don't have participating in research. Now, there's two reasons for this. What we do know from much work that's been done in the cancer community is that if a person is participating in research, in medical research, they generally get better outcomes, even if they're getting the standard treatment. Why? This is because teams that can conduct research generally have more resources, more ability, more interactions with colleagues across the whole United States and the world, and can offer new cutting-edge treatments to patients, but also offer even the routine care. Routine is nothing in medicine is ever routine, but even the care that's not experimental, that's not investigated, gets offered in a more robust way. So number one, research participation does really help drive better health. And we got too many people who are being left out of research participation. Then the second thing is people are all different. Okay, we looked at the map. We can see if you live in a different place, if you belong to a different community, you're going to have different health. You're going to actually need a different way of solving your health problems. Health is deep as a community event and is affected by the community. And if we aren't in these communities, then we're not going to be making progress for them. And then you can see here kind of the usual communities we think about, but I think you can also hear by what I'm saying, I take a very broad view of this, but traditionally we don't have a lot of data we need to do better for people who are older, uninsured, belong to some major minority groups, live in rural locations where it's 100 miles to the doctor's office, have many other comorbid conditions. When people are sick and they got a lot of things going on, sometimes they're left out of research because we don't want to add too many things to the study we're doing. Well, we've got to stop that because these are people we need to take care of. So we need more knowledge about them. And also, little tricky thing, people who are not part of institutions, organizations, doctors groups who are used to doing research tend to receive more non-standard treatment for all kinds of funny reasons. Next slide. And we know the barriers, could be you can't get to the doctor. It could be you don't have the funds that it takes because healthcare can be expensive even if you have insurance. It can be you're working 2 jobs trying to get going. Who's going to go to the doctor for your healthcare there? It could be that you don't have anybody to watch the kids. Think about it. What if a woman like me doesn't go get her mammogram that can save her life because there's nobody to watch the kids? All these things are barriers. They're not only barriers to care, they're barriers to research. Next slide. So here is a very important principle for us at NIH. Our research encompasses the laboratory, the clinic, and it does not stop at the door to the doctor's office because it has to go deep into the community. And we all know we're all human beings, but all of our communities are beautifully different in wonderful ways, but also in ways that impact what our health can be. Next slide. All right, I'm so excited about this. This is the initiative, brand new thing we've got at NIH that's near and dear to my heart. It's a new program called Communities Advancing Research Equity for Health, Care for Health for short. What does this do? You can all read the words on this slide, but let me tell you why we did this first. We have to be humble. We don't understand the best ways to bring health to many communities because we're not part of those communities. We have to get into these communities where research has not been done before. Again, because those are the communities who have the worst health. And we can't assume we go in there and know, number one, what people really need. Number two, how people really want to work with us. And so we have to learn from them. So the principle of care for health is step one. We get researchers who go to and into and ideally are part of a community. We first ask the community in many different ways to do this. What do you need? What is you tell us what's your biggest problem? I can look at the map like anybody else. I know where, all the different maladies we worry about are the highest, but I want to know what your community considers your biggest problem, because that's going to be top of the list, okay, for what we are going to try to work with you to study. And it could be, and this is the beauty of being the entire NIH, not just the National Cancer Institute, but all of NIH, because when we go into the communities, we're going to say, well, okay, what is the problem? Is it high blood pressure? Is it obesity? Is it maternal health? Is it mental health? Is it substance abuse? Is it cancer and cancer screening? Any of those things, NIH can bring a research program that can engage people in that. So I'm pretty sure that there's not much that people can tell us, this is our biggest concern, that we're not going to be able to bring a program in to bring that to bear. I'll tell you the reason why. There's 2 reasons why we've developed the program this way. First of all, we have to be humble. We don't know what's going to work best for a community. And number 2, we don't expect or demand people's trust. We have to earn it. It's an act of trust to participate in research. It's an act, and we know that. And I think the way you earn trust is by being there, being present, and showing that what you're there to do is to listen to what people need and then help them get it. So that's the overall principle of Care for Health. So what are the nuts and bolts and how we're going to do this? What we're going to do is we're going to address these research issues important to diverse communities, particularly those underrepresented. We're not going to be helicopter in, helicopter out. We're going to be in there for the long haul. This is what it means by this middle: achieve longitudinal direction of clinical data to assess people's health across the lifespan. We want the moms, the babies, the kids, the adolescents, all the way up to great grandma and great grandpa, and understand what we need to do, how the community supports their health, and how we can support that community to make it even better. And then the last thing I will say is this is based off of primary care providers. Why? Place where I grew up, there weren't any oncology specialists, there weren't any cardiologists. We had our local primary care doc, like my uncle, who went around the whole state taking care of people. Primary docs are on the front lines of health, and they haven't been empowered to do research very much before. Why? They're too busy. They're on the front lines. As you know, during COVID, we lost a bunch of them because they burnt out. And so part of this is we have to make it possible for primary care providers to be involved in research, to bring research to the people in their communities. And that's going to take a lot. It's going to take investment. It's going to take time. It's going to take long-term sustainability to have that kind of a practice active and viable for our communities. So that's the other part of this. It's the addressing what the communities need, and also empowering, supporting, and really ensuring that the primary care provider, which helps keep everybody healthy, will be the one who will be our partner along with the community members. Okay, next slide. So now my next topic, long COVID. So we got hit with a new and terrible disease in early 2020. And it wasn't too long after that we started understanding that some people weren't getting better. Many people were dying, but even those who survived, many of them still had troubles, and some not such a big deal. My husband lost his smell, which he tells me, living around my two teenage boys is probably a good thing. But no, he got his smell, not a big deal in his life. But other people, some people, after their COVID, have such severe fatigue they can't get out of bed. Some get this weird tachycardia syndrome where they can't, if they stand up suddenly, they pass right out. Some have brain fog, they just can't find their keys, don't know where, just don't get through the day with the sharpness that they had. And these aren't those of us who are getting older where that happens to. These are young people. And there's a bunch of other symptoms, chronic headache, joint pains. And we know this is caused by the COVID virus. So we had to figure out how we were going to treat this. We did a very large study, 30,000 people across the entire United States. Dr. Gary Gibbons was the leader of this in the NHLBI Institute at NIH, along with the Neurologic Institute and the Infectious Disease Institute. They did a brilliant job with the grace of 30,000 people to actually figure out what long COVID was, what symptoms, how we could diagnose it based on symptoms. And then after that, they've launched a series, number one, of clinical trials, but even more important, we recognize we need a lot more understanding of the biology of what this darn virus is doing to people. Is it staying in the body and replicating even though, has the body not been able to clear the virus out so that the active virus is still there? That's kind of our leading hypothesis right now, that why these people are not getting better, but we don't know for sure because we don't have a test. Believe it or not, what is it, 2024? We still don't have the ability, when these sneaky viruses hide in our tissues, to detect an active growing virus. So right now we're based on symptoms to identify people. and were based on a couple of clinical trials to actually treat the disease. One of them is keeping up with antiviral therapies to try to help the body clear the virus. There are other immunological treatments to try to boost the immune system to get rid of the virus. But I think I've told you the other thing I want to say before I move on is from this slide is that the sneaky virus can be anywhere. You can see here we've listed all the organ systems. It really is something that has a terrible effect on some people's bodies, anywhere from 6 to 10% of people. I want to tell you two things that we've learned for sure from the big data systems. Number one, the best way to prevent from getting long COVID is to have if you do get an infection with COVID, to have it be as mild as possible. And the way to do that is to get a vaccine and to maintain your vaccine. Because vaccine, doesn't completely eliminate you ever getting COVID, but it sure helps in a very dramatic way keep people out of the hospital from having a fatal response to COVID and from getting long COVID. And believe me, long COVID is something we'd much rather prevent than try to treat. That's number one. Another result that came out that is really important is that pregnant women who get COVID are more likely to go on and have long COVID. It's another solid fact we know now. And so any person who is pregnant really also needs to take double protection to ensure that either you avoid COVID if at all possible, or by wearing a mask if you're going to be in a big crowd, especially when we see the waves like we just had, or definitely be vaccinated. Okay, next slide. There's a lot of things that this Recover program has done, understanding the clinical diagnosis, defining the risk factors, studying the pathogenesis. That's a long medical word that means what is this bug actually doing to the cells and tissues of your body? What's it doing to your immune system? We have to do all those things before we can really be smart and identify ways to cure this. What are our guiding principles for all the research we do? But we're practicing them, practice what we preach in long COVID, patient-centered. We don't call people who participate in research subjects anymore. They're not our subjects, they are our partners. And that is absolutely critical. And if they're our partners, they also help us design the studies so that the results are going to be more meaningful to them. It is national scale. It's very inclusive, diverse participation. I am so grateful for the communities that have joined us from all walks of life to help us conquer this. And then we bring in our scientific vigor, standard methodologies, scientific rigor, so that when we get an answer, we know it's the truth. We know we can count on it. Next, and then last one, adaptive approaches based on emerging science. We learn, we change, we grow, we get better. And we constantly have to adapt. And I think this is something that sometimes is hard for the public to understand. Well, wait a minute, you've been telling us forever, do it this way. Now you want us to change and do it a different way. We need to be able to adapt when our science tells us there's a better way. Next slide. So next phase, and I think I'm almost ready to the end here, is we've now going to launch, we've learned a lot in the last couple of years. We're now launching something called the Recover Treating Long COVID, or TLC phase. We're going to launch a lot more trials based on what knowledge we've had. We're having a big meeting next week, starting next Monday at the NIH campus to bring together all the experts in the world. We've got 1,800 people signed up to be online, and we're going to have them participate. Healthcare providers, advocacy organizations, the federal government, everybody to weigh in on this and take a look at everything we've learned and now move forward with new knowledge to do research even better and help plan the next round of long COVID trials so that we can conquer this. Next slide. One last principle, the most important one at NIH. Our work is never finished when we deliver scientific discoveries, although that's what we are here and have to do. Our work is only finished when all people, and I do mean all, are living long and healthy lives. And this is the principle we live by. Next slide. So thank you again for letting me meet with you. This is wonderful, and I look forward to your questions.
That was outstanding. It reminds me, and Sister Rudene, I was thinking about this of a couple of talks we've had where you can literally look at the fact that there's this disconnect between people doing the science and how the science actually gets to people. And to hear from the top research program in the land that that community is a focus, I think is really not only refreshing but energizing, particularly for our group. So thank you for that. I was going to turn the floor back over to Sister Rudene.
Again, I echo everything that Dr. Winn said. That was amazing. And thank you for telling us what's going on at NIH now. I have to tell you, my phone started blowing up when you started talking about the CARE initiative at NIH. We have a wonderful pastor out in Northern Neck, Pastor Tyrone Williams, who asked a question about how could a particular rural community actually participate in this study. Again, I know you know everything about every little dot on the map in terms of cancer mortality and death rates and whatnot. But the Northern Neck is an agricultural area where cancer mortality is one of the highest in Virginia, I dare say the nation. So how can a community sort of raise their hand to say, yes, I'd like to get involved?
I know. And it has been just so heartwarming to hear these responses, right? So, okay, here's what we're doing first. You probably all know, I don't know, I think it's public knowledge, the NIH, this is a new program, never been done before. And NIH kind of got a cut in our budget this year. So we didn't have a lot of extra money to be going out making brand new programs. How did we do this? We couldn't wait. There's no way we were going to wait. So a bunch of our institutes and centers, kind of everybody chipped in. This really is, people say, oh, NIH is just some big silo. The cancer people don't never work with the lung people and all. Oh, no, quite the contrary. So across the centers, they pitched in. And what we have done is we have got the resources. They'll be announced next week publicly to fund 3 major hubs. And what those hubs look like is it's an academic center, maybe VCU one day. It's an academic center with the research team there. But then that academic center shows us, which I know Dr. Winn is the master in this, how they are able to, who their communities are, who the communities are that are connected with them, and then identify where the team needs to go, the team from the home hub needs to go and bring those communities in. Now, what do we bring? We bring the resources, the technologies, the help to give those primary care doctors the support they need, give them the tools they need, and the funding and the time to be able to do the work. So it's coordinating through a major hub and then goes out as far as that hub can bring it to the community. And I kind of think it's going to be as far as our money is going to stretch to bring it to those communities, right? We're going to start in a pilot phase because we've got a lot to learn first before we scale to the whole nation. So we have 3 major hubs starting this year. And I think you all know the federal government turns over its funding year on October 1st. So I got 3 that are coming in this year. And then very short after, there's going to be 3 more. And these are places that have applied to us and showed, here's our communities. Here, we want to be part of this. But it is absolutely my goal. And I'll tell you, every time I go to meet with our Congress people, I tell them, hey, we need this for the whole nation. We can't leave anybody out. That whole map needs to be filled. So we're going to start over this year and next year with these 6 hubs. We'll learn a lot in the first years about how to do this. And by the way, the hubs are deliberately chosen to be in very different parts of the United States, but the common principle is they are all it's totally focused on primary care in mostly rural communities to start with, but very soon our inner city challenged communities as well. So stay tuned because I know I'm determined that at some point, communities like yours will be involved in this, hopefully tied very closely to your wonderful local friends.
How wonderful. And by the way, we have at Massey, we have a tagline where we talk about one team, one fight. And really that it really is to align our efforts around making sure that our communities are healthy. And so in that context, we also understand, and we've had lots of meetings with us, and particularly this group, about raising the awareness in our voices about what the great work happens at the NIH. In that context, there's a question that I just had, though, about given the fact that you're the head of the NIH, I think I'm getting this right, and the fact that we know that obesity is an epidemic in the United States. How is the NIH addressing research related to the obesity epidemic that really is driving what we believe is a lot of diseases from, diabetes to cancer?
So many different directions. Okay, let me start with the one. How did we get our obesity in the first place? I'm sure you all know about this whole thing we're all really intensely studying in the field of ultra processed foods. When our forefathers and foremothers were out there with their, eating what they grew and with their vegetable gardens, they didn't have this problem. They were healthy. They were living off the land and they were healthy. But over the next 100 years, we got addicted to this. And I think addicted is the right word, that our neuroscientists have actually done the studies. And for these ultra processed foods that, are tested on us for us to just want them and we don't want to eat one, we want to eat the whole bag, it lights up all the same sensors in your brain as some of these other addictive substances. So those kind of foods are not. So number one, the food we eat is really important. I know we've been saying this forever, but it's actually even more powerful to have this new brain imaging to show that's exactly what that stuff is doing, So I'm not going to call out anybody's favorite munchies, but they're not really so good for you. Okay, back to grandma's garden would be a whole lot better. So there's that, and there's how. But I'm being kind of facetious here, but there's also, what is the best way? Because we have to feed everybody. We have to have a food supply. We have to have a food chain. And, not everybody's going to have a garden in the backyard. So that's a big one, is food. And there's a whole initiative called Food is Medicine that we have across all of NIH. And that's one of those other overarching things, goes every institute and center, everybody's interested in the Food is Medicine program. And if you want to, you can kind of look in there and see what's going on. So that's one we're doing. Another one is, boy, we learned a lot with these GLP-1 drugs, these new obesity drugs. Boy, did we learn a lot. We learned that we thought it was just fixing somebody's metabolism, so they weren't so obese. Guess what? They had fewer heart attacks. They survived a heart attack if they got one. They were, believe it or not, the National Institute on Drug Abuse has data showing it's easier for them to, once they rehab from drugs, to stay off drugs, even. Because it's about this thing that's driving us to eat too much is similar to all of these kind of craving behaviors. Who knew? And so now there's lots of work that intersects with the drug abuse, research and mental health research community and substance abuse and obesity, and learning that conquering our metabolic or getting our metabolic part of our body into the right way has effects on so many different diseases. There's lots of research going on there. And then, I think we're going to see more and more of this very quickly. Let me just add, this is another area where I don't want anybody left out, because these drugs affect everybody differently and everybody's life is different with regard to what led them to be obese too. It's very different. Your lifestyle, your community, your environment is very different and has an effect on this. So all of those factors have to be taken in place. But boy, the benefits, if we get this under control, are going to be tremendous.
I can't tell you how many questions are just coming at me from all directions, but I'm seeing that I only have like a minute.
Oh, I'm sorry.
But I just want to plant a few seeds, and maybe might respond to it in the chat. But one question, again, I'm just going to rattle them off, and you can just decide which one you're going to take. Okay.
Okay.
From Dr. Tosis, who's all about data. If you know Dr. Tosis, head of COE, she's all about data. She wants to know what initiatives are in the pipeline to enhance data collection methods that ensure small, underrepresented populations are adequately
Yes.
captured in research.
Okay, remember when I was talking
how-
about, okay, remember when I was talking about getting these places resources, tiny little clinic in rural Wyoming where there's like one doctor and, a computer, that's it. That's part of the tools that Care for Health is bringing in. They're bringing, and it's not fill out all these forms and, vax them to us. No, it is the electronic abilities to gather data. And it also goes to people, wearing a Fitbit, and finally, remote people. Okay. Right now we have some infectious disease problems in certain communities, in very remote communities that can't get into the doctor's office. What do? It's the COVID mentality. We send them a test, they do the test, they take a picture of it with their cell phone, that goes to some remote doctor, they mail them their antibiotic, or they mail them their Paxlovid for their COVID. There's so many other things we can do to make sure people don't get out. But as we roll out those things, we have to get the data. And the last thing I want to say to a person who cares about data, we've spent too much time doing snapshots of people. People have a whole life. And what you did as a child matters when you get to be 80. And so that's the other approach we have, is really taking people as their whole life.
That's awesome. This was supposed to be lightning round, Dr.
Okay, keep
Bertagnolli,
going.
but you're not doing that for me. But
Okay,
I
I'm
have
sorry.
one more for you. It's from Father Tochi. I think it's a great question. How will the NIH track the progress within the community, and how can the faith communities be of help in rebuilding trust? You said that was critical, right? But people trust their churches or their synagogues,
Oh, yeah,
or wherever it is that they worship, right? So how can we be a help to you?
Well, you are the pillar of the community, right? And so that when I said we're coming into the community and saying, what's your biggest problem and how can we help you with that? Well, that's going to be the faith-based community that we're going to come to and ask that question. You will help answer that first question we need to know. And then once we get in there, we need to work together. And part of this figuring out how that can happen in a sustained and really thoughtful way is part of these pilot phases of the whole Care for Health thing in the first place. Because the other thing about trust is it can't be one and done. It's got to be every single day, every single new sun. We have to make sure that we're there and have an enduring relationship.
I got to say, thank you for that. And I hope everyone now knows my phone is blowing up and all these other things about, other people sort of saying, can we have her back? And we'll get to that later. But I want to say thank you for sharing your time with us. It's been special. And in fact, I think that everyone on this call and everyone that's participated now understand why when I talk about that we have great leadership at the NIH and I talk about you, I'm glad that they've got to experience that for themselves. So thank you so much. I know we're at the end. I'm hoping that Dr. Bertagnolli, that this is the beginning of a relationship. You will have a community, and I've gotten in my chat right now, by text, that we're going to do more than pray for you. Just tell us how we can help. That's coming from that fact. That's what this group is. And so, as we talk about community voices, as we talk about championing and getting the word out about science, research, NIH, and how it's impacting community, you can count on us, the Facts Faith Friday crew, to support that. I know we're coming to the end. I was going to turn this over to Rudene. I think we actually have a prayer going out.
Yes. So, again, Dr. Bertagnolli, you're an angel. You're all the most positive words and attributes I can say about you and your journey. But thank you so much for being here. Announcements we're going to be put in the chat. There's some upcoming events we want people to pay attention to. But again, as is our custom, we ask for one of our faith leaders to close us out in prayer. And I'm hopeful that the prayer will include a special blessing on your life, Dr. Bertagnolli, because you've really blessed our lives today being here. Dr. Letitia Clay Crawley will lead us in prayer.
So God, we thank you. We thank you for the shared wisdom and collaboration and recognizing that science and faith work together as we understand your creation and your care for your people. God, as we prepare to leave, we ask your blessings on the knowledge we've gained and the insight we carry with us. May we now be vessels of healing and hope, using the information to serve the communities you've called us to, especially those who are marginalized and underserved. We pray a special blessing, oh God, on all of the medical experts and those who are doing this fantastic research, oh God, that you may allow them to continue the work with renewed strength and compassion, and guide them, oh God, as we seek to make a difference in the lives of your people. Bless Dr. Bertagnolli tonight. May she continue to do the great work and lead us in a wonderful way. Continue to unite us in the purpose and passion as we move forward together, knowing that through your wisdom, science and faith can work hand in hand to bring healing and wholeness in the world. In your name, amen.
Thank you. That was a word, Dr. Letitia Clay Crawley. Thank
Come
you
on
so
now.
much.
That's the way we end the Friday. Thank you, Dr. B.
Thank
Hope
you.
to see you again.
Thank you all.